Welcome to the Rehab and Performance Lab, the MedBridge podcast where we dive into the world of orthopedics and sports. We're here to unpack the big topics, offering you practical insights and valuable tips from some of the most inspiring professionals in our field. Don't forget to visit medbridge.com to get your continuing education credit for this episode, plus access bonus resources. Welcome to the Rehab and Performance Lab, where we have conversations about bridging the gap between research and the real world. I'm Phil Plisky, your host. I'm a professor, author at philplisky.com, and a consultant in professional sports. And being a physical therapist, athletic trainer, and strength and conditioning coach, I come at this from many different perspectives. We really want this to be really research-based, but more importantly, practical for you. So I'm excited about our topic today. We have navigating shoulder rehab and surgery, and I'm joined by Lenny Macrina. He is the co-founder and director of physical therapy at Champion Physical Therapy and Performance in Massachusetts. Welcome to the podcast, Lenny.
Thank you, Phil. Great to be here. Always love to work with MedBridge. They are an amazing company. So excited.
And I like working with you too.
I like working with you. Oh yeah, you work with MedBridge
right.
too.
That is a part of it as well. All
yes.
right. Hey, could you tell me a little bit about your background so the audience knows?
Yeah, a little about me. I graduated physical therapy school in 2023. That's hilarious. 2003.
That's great.
So I've been doing this for about 21 years now. Graduated from Boston University, moved to Birmingham, Alabama to work with those guys down there, Mike Reinald, Kevin Wilk, Dr. Andrews, all that group. My 2-year commitment in my head turned into 12 years. And so got a ton of experience down there, being able to publish research, speak nationally, and just being able to get involved with everything that they did down there. And then in 2014, I moved home to Boston, Massachusetts to help open up our facility, Champion PT and Performance with Mike Reinald. So we've been open. Our 10-year anniversary is now our cash-based PT clinic in Boston. So I've had a fun 20 plus years of experience. I'm glad I can share it with you guys today.
That's awesome. Now you're, and I'm going to say this, and I know you wouldn't say this, but you're an expert in several different areas in sports and orthopedic rehabilitation.
I'm not afraid to say it, Phil. I'm not afraid to.
You're not afraid to say it. Well,
no,
good. All right. Well, fantastic. That's well, good. Well, you are an expert. Well, I mean, at a certain point in time, you have to become one.
Right.
But tell us. So specifically with the shoulder. That's a really big passion area of yours. How did that kind of come about, and how did that evolve over time?
Yeah, I mean, I think just going to PT school in general, I went to PT school because I was interested in anatomy, potentially going to med school, but then my background in baseball. I grew up playing baseball, high school and college. And then it just naturally fit going to Birmingham and working with Glenn Fleissig and Dr. Andrews and Mike and Kevin and everybody down there. We saw so many baseball players, and it turned into being able to do research, help with research, publish research, see people with shoulder injuries, and it just kept going and going and going. And we still have that passion now. And I've seen so many people after rotator cuff repairs and non-op and being able to digest the research, present it. And so it just continues to grow. I love it. I think it's a joint that people tend to get a little overwhelmed by, but I think if you keep it easy, like every other joint, that keep it simple, stupid kind of, term, the KISS principle, I think you can overcome that and do a great job with your shoulder patients. So, yeah.
That's awesome. So you mentioned rotator cuff rehab there. That's not necessarily the first thing I think of you with baseball and things like that. But I think you really haven't been a seasoned clinician until you've seen your fair share of rotator cuff repairs. So let's just dive right into that. Like, what is the research telling us now about rotator cuff repairs? Should we be doing them? How do we know when we should be doing them? What does that look like?
Yeah, no, I think all the surgeons can retire and just go.
They're done. Everybody can be fixed by physical therapy.
No, I mean, it's so complicated, and I wish it was just you could it's an algorithm. If this and that, you have this on an MRI, you go to surgery. If not, you go to PT, and it's not that simple. It's an N=1 kind of. It does your experiences and the research and the person themselves. How are they presenting? And you really have to try to figure that out, and it's not easy. Definitely surgery is needed for a lot of people. I think there's a lot of people can get away with not doing surgery and doing physical therapy or some form of rehabilitation with an OT or a PT, because the research is mixed, right? Our research is not, it's not like we're doing, the highest of level where we have double blinded randomized control trials where we have a control group all the time. It's not that easy when you're dealing with humans and pain. It's not easy to measure pain in general, never mind when you have humans and you're not just
Right.
looking at looking under a microscope for cells or looking at the amount of concentration of something in the blood where you can measure that.
Right.
It's
Or
not
even,
that,
yeah, what do they have to get back to work?
right.
Do they not to? Are they trying to get back to
Yeah.
sport? Are they in the mid season? Are they off
Every
season? What all that
situation is
matters.
different. How much time do we have? Are they a senior trying to play a sport? They need to show videos to get into college. Are they 65 years old, retired, and just want to golf or work in a garden or be with their family? Or are they 40, the peak of their working career, where they can't take time off from work, but they have this massive rotator cuff tear that they sustained when they fell off a ladder, something
Yeah.
like that. So it's not always straightforward. But I think if you look at those situations, each one will lend itself a theme and
Yeah.
something that you can kind of sit with and hopefully help make a clinical decision. And you're bringing the person involved in the decision making. It's not just like they come to you for PT and you're like, no, 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 no. You need surgery.
Right.
I don't care what you think. You're going to have surgery. Or, oh, you don't want surgery? Sweet. Yeah, I agree with you. I think you have to guide the person based off of what you know, your experiences, what they present with, what they are telling you. I think that's the key is what are they telling you? Do they want to do surgery? Do they want to go through the process? Do they have the time to do that? Also knowing what the MRI says and what the injury was and what the factors are involved. What's their medical history, their comorbidities. There's so many different things
Well,
that,
let's dive into that though,
yeah,
because one of my least favorite answers. I get to both do consulting and private practice
yeah,
and teach, but one of my least favorite answers of physical therapy school, of athletic training school, is it depends, right?
yeah,
Like, of course it depends, right?
it depends,
But
right?
but you know, but and
Yeah,
but let's put some real context to this.
yeah,
Like, the context does matter, is what you're saying.
yeah,
And so we have a 68-year-old with this is hypothetical, but we've all
of
seen this
course.
person, right?
Yeah.
Uh,
I
the
see the
68,
67-year-old, but you
yeah.
can do
Oh,
assume
okay. Well, he's
68, that's
okay.
fine.
We're
Yeah.
close. Yeah. So,
Close.
so, so a 68-year-old who has a rotator cuff tear.
Yeah.
What are the factors, and which way would you go based on those factors? Meaning, should they have surgery? Well, who's a
Right.
surgical candidate? Who's not? Maybe give me an example
Right.
of each of those.
Right. I think the chronicity of the tear, how long have they had the symptoms for? Have they had it for a while? I think a big thing is have they tried physical therapy? I think that is a big thing, and give it a couple weeks, few weeks, 4 to 6 weeks. I think if they've had the pain for a while, they've been fighting it, it finally got worse. You do an MRI. Does the pain kind of match their symptoms, and can you replicate it in PT? Can you help them in PT? Meaning doing some manual therapy stuff or just giving them exercises to do and talking them through their situation. I think being able to dissect the MRI, the report, again, we can't treat the MRI, but I think you can get
Right.
some clues from the MRI that may help guide the situation. Do they have time? Do they have 6 to 12 months to take time off or a few months easily from a job? Do they have comorbidities? Do they smoke? Is this a work-related injury? Do they have diabetes? They have a history of having a previous surgery that did not do well, a history of frozen shoulder. I think those things
Mhm.
all play in my head when I'm trying to help them. But that 60-year-old, 68-year-old who has some shoulder pain, it's kind of a new onset, no specific injury. They didn't fall, it wasn't something specific. I would try PT. If it's a full thickness tear, it seems like the research is almost screaming surgery is in their future. It may not be now, but if they have a partial thickness tear that shows up on an MRI and it's isolated to one tendon, typically the supraspinatus, then I think it's something that you try rehab for, knowing about 1/3 of those people, I think is what the research roughly says. 1/3 will have a progression of their tear from a partial thickness to a full thickness and probably will have surgery down the road. The problem is we don't know who those people are. So a trial of PT is usually warranted to try to figure that out. If the tear goes too long, now we're in trouble, right? Now we have maybe some retraction, we have some fatty infiltration into the muscle belly, and now their outcomes plummet. So you have to weigh all that, what the MRI is telling us, to try to figure out if they are a surgical candidate or a continued candidate for physical therapy or rehab.
That's awesome. And that provides a lot of clarity. One of the things I've heard you talk about that I really like is, the concept of, maybe rehab first before an MRI. What's the danger of doing an MRI first and then rehab? Why would you have that preference?
Yeah. I don't. I think a lot of people would say don't get an MRI. I'm not afraid of an MRI because I know I can help translate that MRI. I think in a safe way for the patient. I think a lot of times as they get MRI, the surgeon goes over it and now they come to you for PT like I'm having surgery. Like, whoa, 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 let's pump the brakes. Let's see what's
Yeah.
going on. I'm not afraid of explaining what the MRI
Let's
results are.
let's dissect that right here. Just give me,
Yeah.
tell me I'm that patient right now that just said, "Hey, my rotary cup is torn," and and the doctor says I might need surgery.
Right.
What would you say?
I'd say it's our first day of PT. I would say, or it's we've been doing rehab for a while. I'm not surprised, unfortunately. I think you are probably going to be a candidate for PT based off of your pain has continued. We've tried to do the things that we think are going to benefit you and it hasn't worked. Or, hey, we haven't done PT yet. Your symptoms, yeah, they're rough right now. Let's give it a couple weeks. You're not gonna probably do the surgery tomorrow. Can we give it a few weeks of you're tight, your motion's not good. You don't shrug. You have pretty good motion. You just have that pain at a certain arc of motion. Can we get your shoulder to calm down? You've had a lot of stress in your life recently. Can we kind of talk you through that and give you some exercises to do at home? You've been to a previous PT, and I think you could have done a little bit more. They kind of kept it basic to yellow therabands. I think let's add some dumbbells and let's add some manual therapy. A study by Lenny Macrina just came out that showed adding manual therapy to exercise was better than just exercise. Again, control groups are lacking, and we can argue the research all the time, but there are other opportunities to help the person improve their pain than just basic yellow TheraBand. Nothing against TheraBand, the company, but I think the lighter resistance type exercises are, we can be better than that. We can progress people better based off of their presentation. I think also diagnosing them correctly too. Did you take any good objective
Right.
measurements? Did you take some handheld dynamometry and measure their strength, objective number wise? Do you have any special tests or special questions that you give them, a constant score or something like that? We can monitor that over time. So I think there's so many different things that we can monitor in our patients and try to improve upon. And then you start showing them, look, you're doing this, and you seem to be feeling better. I think we keep going with this. Let's give it a couple more weeks, and we can kind of push things along. And so I think there's so many different ways that we can address these than just kind of jumping into a surgery. I think it's just talking them through in the right way and talking to them and respecting them. I think and hearing them to let them have a voice.
Well, and that's just so true. And like the context you provided really helps clarity. If you look at it and you look at the research and you say, okay, well, yeah, they've got a shrug sign, they're lifting up their
Right.
shoulder. They're over 65. They have pain at night.
Right.
And they have, let's go even farther. They have a drop arm,
Right.
sign.
Yeah.
Gosh, that's a surgical
Yeah.
candidate. We're going to give
Quality
you,
of
we're
life is
going to,
bad. Pain
yeah.
at night. I mean, that's
Yeah.
all. That's screaming. It's that. But those cases are
Those
relatively.
are easy. Those aren't the ones
Yes.
we're talking about, right?
Right.
Like
Yeah.
like that person I'm going to give, I'm going to say, "Hey, here's your exercises to gain your mobility prior to
Right.
surgery, keep your
Right.
mobility prior to surgery, and we're going to be so excited to see
Right.
you afterwards." But it is the cases of that trial rehab. How do you know, let's dial in a little bit and give context to, I'm kind of undecided. MRI says it's a partial tear.
Right.
And how long do I give for rehab to high quality rehab? And I
Yeah.
really like that you kind of specify that because that is important. High quality rehab. How long do you give that? What does that look like? How do you make that decision?
Yeah, I would say like most other injuries, we know a lot about the person after a few sessions, believe it or
Mhm.
not.
Yeah.
You can kind of get a feel. But I think if we can go 4 to 6 weeks, something like that, 6 to 8 weeks at the most, I don't think we're going to affect the tissue. I don't think that we're going to affect the long-term outcomes if they have to elect for a surgery down the road. Oh my God, sorry. Down the road, that's hilarious. You guys realize that like these Apple things are we can create like thunderstorms. Sorry, everybody, but
Great.
we get some balloons in the background. But I think if you give it a good month to 6 weeks, and they're compliant with their exercises, meaning they're religiously doing it, they ask good questions. they're coming to PT consistently. They're reviewing this stuff and they're giving you good clues that they know what they're doing. And their pain is either improving or not. I think that's telling you, I think it's time we make a decision. That's usually pretty respectable, I think, is a month or so. And I think it's not going to affect long-term
Right, because
tissue
we're
quality.
activating the musculature in there,
Yeah.
we're keeping it from atrophying,
Yeah.
and again, we're not doing it for a year and waiting to get a
No,
fully
no,
retracted.
I think a month or two at the most is more than adequate to
And it
give
depends
somebody a
on the
shot.
trajectory too, right? Like if it's slow but steady progress is different than no progress, right? I'm pulling the
Absolutely.
trigger faster on no progress than I am slow and steady.
Absolutely.
Fantastic.
Absolutely. But I'm always telling the person down the road, if the pain returns or if your pain returns worse, we got to figure this out. That we might be, we got to either get back into PT or figure out why things have happened, because that oftentimes will happen with rotator cuff tissue, where that anterior tear that was a partial thickness turns into a full thickness, the full tendon, and going into the infraspinatus, depending on their lifestyle and their medical history. So, there is a path down the road potentially. But if we can get them a year or two of no surgery, I mean, amazing, or more,
Yeah,
maybe they
or
can
more.
avoid
Yeah,
it all up. Yeah,
it never ends up.
yeah, yeah.
Now, you said something that I like. We can't just treat off the MRI. Can we talk a little bit about the research that says after a rotator cuff repair,
Hmm.
the orthopedic surgeons are having like a heyday right now in the research, saying it depends on which camp of orthopedic surgery you are in, because
Yeah,
either orthopedic surgery fixes everything or it fixes nothing, according to the two camps, right?
right.
And it seems that in a fair number of people, maybe up to 50%, that the repair fails. Like if you do redo
Yep,
the MRI, the repair has failed, but their
yep,
function is totally fine.
yep.
What do you make of that?
I know, and that's always my argument. I tell people that. I mean, if you look at the research, I feel like it's like 14 to 96% have retear rates. And you're like, what does that mean? That means nobody to everybody retears their cuff. There was a study. Oh man, it was probably 15 years ago. Galati, I think it was out of HSS. He did serial MRIs of people after their cuff repairs, and I think our studies tend to stop at around 2 years looking at
Mhm.
MRIs after a cuff repair. He or she kept doing serial MRIs on people, and the retear rates went down. So the healing rates went up the more you looked at the tissue. So at 5 years, there was like an 83% healing rate versus at 2 years, it was like 68% or something like that. So it's interesting that is our research flawed in that we're not giving the tissue enough time. If you look at ACL rehab,
I was gonna say,
it
like,
probably ta-
you took the words out
it
of my
probably
mouth
takes
there.
2 years for at
2
least an
years.
ACL, right? And we don't
Yeah.
want to, we hush hush, we don't want to talk about that. I know
Right.
Tim Hewitt is a big advocate of that on social media and his research. Tim's a friend of mine, but maybe we're not giving the cuff enough time to heal. And again, yes, I do think that you can't treat the MRI. That these people are pain free. Whatever the surgeon did, disrupting the tissue, reattaching it, maybe they have a little bit more of a bridge repair going on in there and stabilizing the shoulder better than their native tissue was prior to the surgery, and they're living somewhat normal lives pain free. I can't argue with that. So
Or is it, is there an analogy to be made if we're going to talk baseball a little bit, in the UCL reconstruction, Tommy John, and we go, oh yeah, now, yeah, after coming out of that, I'm pitching harder and
right,
I feel better and all
right,
that kind of stuff.
right,
Well, was it the reconstruction? Yeah, or maybe the
yeah,
year and a half of high
right,
quality fundamental
right.
start to finish rehab,
Yeah,
right?
no, absolutely. I mean, you have a 65-year-old who hasn't really done shoulder exercises, may not even be doing any exercises, and now you've given them 4 to 6 months of a shoulder program easily, hopefully. And same thing with the Tommy John. They go in just doing a general weight training program that their strength coach wrote for the whole team, and now they're doing lower body specific for them with their PT. They're doing upper body specific in a graduated progression. They got a throwing program that's just not involving a long toss from 300 feet. It's a gradual
Right.
progression. It's they're taking actually that time off if they feel something, because the PT says, let's shut it down for a week or two. You're feeling more than I like. They actually do shut it down. You have a relative rest where they're not throwing all the time, and now they're throwing in a very finite window, or a very finite amount of throws that the program says. So yeah, I think it's a really good analogy, and I think we see this all the time in just all of our patients that we see, not just for UCLs or rotator cuff repairs. It's a new world for a lot of these people, and so getting them this program or these programs and them sticking to it and,
Yeah, just
and
getting
having a
a little bit of
motivation.
oxygenation to the tissue
Yeah,
and
yeah, yeah,
a little bit of
yeah,
resistance to the tissue. Now
yeah,
it adapts and suddenly
yeah,
we're feeling
yeah.
a lot better.
And the mental component too. They have somebody
True.
that's monitoring them and almost like a cheerleader for them, and like that's awesome. You're lifting 3 pounds now. You weren't able to even raise your shoulder up.
Right.
They come in and they feel like, yeah, they're reporting to somebody. They have accountability. That person is helping them and there for them and talking them through the aches and pains that they may feel, the little setbacks that they have here and there. That it's not a huge setback for them mentally. It's just like, ooh, yeah, that was normal. My PT says normal. Let's get back on the horse and keep riding. And I think you can't underestimate the mental side of what we can provide as a physical therapist to the patient. There's so much we can offer for somebody in clarity, in the rehab, in the ups and downs of rehab. It's just not a straight line of rehab. There's just
Well,
this
just taking
chaos.
the fear out of it, right?
Right. Yeah, absolutely. Yeah.
If I have a partial tear of my rotator cuff and I do rehab and I feel better, and after 4 weeks I'm feeling pretty good, and then I babysit my grandkid and suddenly my arm hurts a little bit
Right.
again. Oh
Right.
my gosh, now is it fully torn? You're like, oh
Right.
gosh,
Yeah.
you and I are going to sit there and go, oh my gosh, but no, just don't even
Right.
worry about
Yeah.
that. That's
Yeah.
a blip on the radar. You're going to feel
Right.
great in 2 weeks.
Yeah.
Versus, oh my gosh, my arm hurts. Now I'm not going to move it. I'm
Right.
going to go in the surgeon, and here we
Right.
go.
Yeah. Which always lends me to, and we're probably going to talk about this, just the mental aspect of getting PT early, getting people into PT early. There is a whole world out there that still says no PT for 6 weeks after a rotator cuff repair. But I think if you can get people in earlier than that, I think we can coach them through the aches and pains that they're feeling. And did they do something wrong in the shower? Did they, they had to take the brace off to do something and they felt something? Is that okay? So I think us being able to talk people through their scenarios is a huge aspect to help them mentally and physically get through it. It's not an easy
Well,
process.
yeah, and again, it doesn't necessarily need to be 5 times a week or anything like that. If
Right,
we can
right.
just if
Yep.
we can just touch base with them once a week, hey, let's get your
Absolutely.
thoracic mobility going. Hey, let's have you
Right,
walk into the clinic first of
right,
all and
right.
and
Get
be a
out
little
of the
more
house.
physically
Yeah,
active. Hey, oh,
yeah,
you want to do some leg exercises so we can,
yeah,
get the healing going. So let's dive in a little bit more on that. If we think about again, there's I'm sure throughout the country. I like what I like about this podcast is I like diving into the context, diving into the controversy rather than having to sit here with a slide up and say, well, this is what happens at 6 weeks. Well, we all
yeah.
know what happens.
Right.
W- Walk me through what you're seeing from the research and clinical practice after, let's say, let's go middle of the road, medium
Right.
size rotator cuff tear. Should we be doing early mobility? Should we be in a sling the whole time? Should we
Right.
have a combination of both? What does research in your clinical practice kind of see in this?
Yeah, it's the exact opposite. So the research says one thing in my opinion. I actually
Yeah.
did a lit search last night just to make sure I wasn't missing anything. But the actual clinical practice is still 1987. Actually, no, I think it's slower now. Um, Not that I was practicing in 1987, but how I'd imagine it was probably aggressive in 87, and then the doctors backed off. But I digress. I see right now for that medium-sized tear, which you described in our hypothetical patient, I see that's roughly for people who are listening. That's about a 2-ish centimeter tear, 2-3 centimeters. You probably get supraspinatus, some infraspinatus tearing. I see no PT for 4 to 6 weeks. I see them doing pendulums, maybe at home, maybe some gripping. They're in an abduction pillow, and they have no guidance. They don't know what to do at home besides the docs that do pendulums or the docs that don't come out of the sling at all. And you'll go to PT when told to go to PT. Versus what I think and what I did I was in Alabama in 2002 to 2014, post-op day one. So you have surgery on a Wednesday, Thursday you're in PT. And we did that safely, and we got people's shoulders moving. Like they were doing passive range of motion. We did a study that came out. When did that study come out? 2004, 5. We looked at using electrical stimulation on rotator cuff patients to produce a maximum isometric contraction on the infraspinatus after small to medium sized rotator cuff tears. Max effort, 10 days out of surgery. So we had their patients about 10 to 14 days out of surgery. We put stim on their infraspinatus, had them do a max contraction into a handheld dynamometer, measured that, compared it to no stim, and published a study in AJSM. And it showed they had better force output using stim versus no stim after recovery repair, 10 days out of surgery. Now we have PT that is nothing for 4 to 6 weeks, and they're in the abduction pillow. I think we can get people moving earlier. I don't know. If they don't want to get them in a few days out of surgery, I respect that. Let them kind of get their bearings. But to have them go 4 to 6 weeks without PT, I think is ludicrous because, again, we can give so much mental coaching to the patient. We can look at their wounds. We can make sure their elbow, wrist, and hand are okay. We can get their shoulder moving safely because EMG studies show less than 10% EMG of the cuff if the therapist is moving the shoulder. Tim Ull has shown that. Dockery has shown that. Numerous studies have shown that throughout the years. And safe too. If you look at a lot of the research that shows accelerated versus delayed PT, which is typically that 4 to 6 week ranked time frame, they do the same. Functionally, they do the same. Re-tear rates are the same. But for some reason, doctors are still in I want them to scar down. They get better outcomes if they scar down. I want some pain in there to self-limit the patient. I don't want the PT to re-tear my repair.
Right.
And so it drives me crazy because we definitely can get these people moving earlier, at least once a week. Give them something to do once a week because we can do it safely and help. We can be on the team with the doctor and be that second set of eyes that they can't be for a lot of the stuff that is going on with the person, and then we can report to the doctor.
It's so interesting when we get to practice for decades, when you get to put an S on the end of decade,
Right.
that's a thing, right? And so when you get to practice for decades, I'm reminded, very specifically here, like think of, again, the analogy to ACL reconstruction, right? It's like, oh, let's shut them down. Let's do nothing, oh, let's avoid the open chain. Let's not do E-stim. It's like, heck no, like there's tons of great research now that says, E-stim plus blood flow restriction, open kinetic chain, let's get that quad going because that's the rate limiting step. I think you're kind of saying there's a strong analogy there in the rotator cuff repair world.
There definitely is. I think it's same thing. I don't want to say it too loud, but same thing with ACL with a meniscus repair. Root repair is different. Meniscus repair and ACL, they do well. We can get them moving early. We don't have to magically stop at 90 degrees, but this is not a podcast about ACL rehab. I just know that there is a body of work out there that shows one thing. We do something else differently because of what the old protocols have told us over the many years that are still accepted.
Yeah, absolutely. So again, I think we can be a little bit more proactive. There's something about, the body is a self-healing mechanism. There's something about stimulating that self-healing mechanism is what we as rehab safely stimulate that self-healing mechanism. Maybe that's a bottom line. Maybe you can tweet that one out, Lenny. So let's go to another hypothetical case scenario. If we were to say, hey, we've got a small to medium rotator cuff tear in a 43-year-old laborer who does a lot of overhead work. What's our clinical thought process on that? Let's assume, like, again, back to that, how long are we going to give? Are we going to give rehab a longer shot or a shorter shot in that scenario, knowing that this is their livelihood?
Right. Tough question.
You were about to say it depends, weren't you? Here, let me give you a new phrase. It's the context of that matters, Phil. That's what you need to say. Right. So the context of that matters.
Right. I would say somebody young who has an acute tear or even a chronic tear, and MRI shows it, and they are struggling to live their life. They can't sleep. They can't do their job. They're going to have surgery. And hopefully the tissue is good. Again, I think that's another thing too, is older people don't have as good tissue as younger people. So younger people, if it's a 40-something-year-old who doesn't have comorbidities and is still, healthy overall, they're going to do so much better, so much faster than that 65, 70-year-old who has chronic degeneration of the tissue, fatty infiltration potentially, and just healing in general. So I think they're going to do well. What would I tell them? Probably at least 4 to 6 months before we're even thinking about going back to work. Probably going to be in a sling for about 4 to 6 weeks. We start some strengthening stuff. When you get out of the sling, you've had atrophy for months and disuse for a few weeks easily. So it's gonna take us at least 6 weeks to get you to baseline, and probably longer, which is now going to be that 10 to 12 week frame, and it's going to take longer than that. And so now we're at 14, 16 weeks, 4 months out of surgery, and we begin to start talking about return to work. But I probably give them at least 6 months to get them back to their job. But I have a very good prognosis for that person. I think they're going to do well overall, as long as there's no other tricks that we are missing. If you know what I mean, meaning
Right.
there's other motives. There's a reason to not go back to work or something, which does happen. Realistically, it does happen in our world. So PTs and OTs and people out there listening, you will run into that. But I think that straight up person who is trying to get back, they enjoy their career and they enjoy being able to weight train again and get in the gym. I think a good 6 month program is going to get them on the road to recovery. But I always tell people, give it a year. You're not going to feel
Yeah.
normal till about 15 months out of these procedures, despite,
Again, to keep harping on a theme, right? Oh wow, what about ACL reconstruction, Lenny? What
yeah,
about hip labral tears, surgery, Lenny? It's just like,
yeah,
wow, there is something
yeah,
magical about active time, like
yeah,
rehab time, where you're
yeah.
stimulating that process. All
It's
right, let's switch
longer than
gears.
people think, unfortunately. It's a
It
lot
is,
longer.
it is, it is a lot longer.
Yeah,
We tend to come week, I think because we say 4 to 6 weeks a lot for a lot of things. I
right,
think people think 4 to 6 weeks means I'm back to normal 4 to 6 weeks. Then we say
right,
4 to 6 months and
right.
we think I'm back to normal at four to six
Yeah.
months. No, you're getting back to work at 4 to 6 months. And
I'm
that is
uh
a different
I'm
story.
always straightforward with people. I set the guidelines from the beginning. Whether it's a Tommy John and ACL, I start from the beginning. I want to hear their perspective. When do they need to be back? When do they want to feel normal? What do they have coming up in their life over the next year? And I start hitting milestones and I count backwards, because I want to be straightforward from the beginning, no surprises, because they do have that 4 to 6 week, 4 to 6 month time frame in their head,
Well,
which is a
yeah, and
good thing.
frequently that's what the physician has
But
told me
yeah,
as well,
exactly, right.
unfortunately.
And so
So we have to
I
reset those
I
expectations.
have to always reset things, yes. And
Absolutely.
I have no problem with
Of
that.
course, I think you and I are cut from the same cloth, and it gets us in trouble, which is great.
Right.
Um,
But
so
I think if you work with surgeons that are like-minded, you've worked with them long enough,
so much
and they
easier.
know you, you know them, there's no problem with being realistic. And
Yep.
they respect that, because now they've done the surgery. The surgery took an hour or two.
Well,
Now
their
they have
outcomes are so
months
much
with
better.
me.
Their patients are so much
Right.
happier.
Absolutely. And they love that relationship. They love that I can talk to a doctor back and forth and talk about them and get perspectives and report stuff. You have to have relationships with surgeons in the area that you get along with, that you think the same, and you go visit, you hang out. I do that all the time. They come to our facility and hang out. You have to have that for people listening to this. You have to be able to get involved with that aspect.
For sure, for sure. So let's look at a different case, a different hypothetical case. Let's
Yep.
say, a labral tear, right? So we've kind of dealt with rotator cuff tears ad nauseum here, and let's go to a labral tear in let's say in a baseball player, so a more active, sports oriented kind of
Right.
person. How do you balance those MRI results?
Hmm.
The 14-year-old, hypothetical 14-year-old, comes in with shoulder pain, and they went to their family practice physician to give him an MRI, and suddenly it's coming back with a little bit of
Yeah.
labral pathology. How do you balance? Or let's make it a little more. Let's say 16 or 18, just to know
Yeah.
they've gotten some trauma to that shoulder over time, right?
I hear this a lot. It's interesting. In my career as a PT, I've seen this evolve, where everybody had surgery. 50% got back probably. And then we realized that wasn't the issue, which is
Right.
scary, that all those people in the early to mid 2000s had they had a surgery that probably was not the best fit for them. But
Yeah.
we learned, just like we learned in the 80s, that immobilizing an ACL at 20
Probably not a
degrees
good
of
idea.
flexion
Yeah.
for 6 weeks in a cast was not good. We learn, hopefully, we learn. It just takes a while. But for that person coming in, we don't recommend surgery. We say it's probably a normal variant that has occurred in your shoulder. Maybe you need that to throw a baseball, or it's very normal for that to occur in a baseball shoulder. and we will treat your presentation, your symptoms, and your impairments. So hopefully, we have some good ways to measure things on the person, meaning total rotational range of motion, handheld dynamometry for strength.
Mhm.
Look at their lower body. Look at how strong they are. Are they maturing? Was there an injury? When does the pain occur? In what portion of the throwing motion? Have they taken any time off? Have they added anything into their programs, meaning an aggressive weighted ball program or a new mechanic that they're working on or something that would have done this, or they haven't rested and they're
Yeah.
fatigued. There's so many different things besides a labrum that needs to be repaired because again we learned that fixing the labrum the symptoms returned or they never got their motion back because they got stiff or they're weak, they stayed weak, or it wasn't the labrum, meaning like
Yeah,
anterior
we
shoulder
rehabbed them.
pain.
Yeah, we rehabbed them.
You're right, the anterior shoulder pain could be, think about it, what attaches in the front of the shoulder. You have your biceps, you have your lats, you have your teres major, you have nerves, you have blood vessels, you have pec major, you have your rotator cuff. You have so many different structures that attach in the front, thoracic outlet, that I think the labrum is the least of my worries. And I have to tell people, if we MRI'd probably 100 people,
Mhm.
100 baseball pitchers, 80 of them would probably have
Right.
some kind of abnormality in their labrum. And you are one of those 80. You are in the majority. So it's very normal. Let's figure out your presentation. Let's come up with a game plan when we can get you ready, likely, in a realistic fashion. And let's have a goal of getting your motion to normalize. Let's have a goal of having your strength to be better. And then let's get you a graduated throwing program and let's see if we can get you back. And a good chunk of the time they do. And they're shocked that that's even a possibility because some of them do have surgery. And you're like, oh, I wish I caught you before you
Yeah,
went to that surgeon who said you need surgery, because then usually their career is changed. And
for
so yeah,
sure. So
try to
one
get
of
them
the
in early.
things, one of the things I really hear in you, and it and it's come through in a lot of different things you've said, but there is an air of confidence in the fact of saying, I've seen this before. I know I can get this better. I remember I did some consulting with a professional in a basketball team, and I actually was helping the PT. And when I was helping the PT, I said to the PT, I'm like, do you believe you can get this better? And he's like, well, I don't want to promise anything to the patient. And I'm like, no, no, no. I'm not saying you're promising that you are going, but do you deep down feel you get better?
Right.
What I hear from you is you deep down believe that when someone comes in with that labral tear, that some high quality rehab will make substantial improvements in that in 4 to 6 weeks. And if it doesn't, then you go to the next step. What do you think about that?
Yeah, no, definitely. I mean, we've done this long enough, and you hope that you these end up in your head. These cases magically end up in your brain, where you can like pull a case out and talk to a patient or
Mhm.
family about somebody I treated a few years ago, or a few weeks ago, or a couple of decades ago. Unfortunately or fortunately, that I've seen this, and we see this all the time. And you got to exude that confidence to the family, because you have to be able to dig into those cases that are in your brain, and it comes with experience. So that early career professional that's a year or two out, I get it. You don't have the experience, but it'll come. I promise you, it'll come. Just stick with it. Read the research. Talk to people that have been doing this longer than you. Learn from them. Hear their stories. Listen to these podcasts. And I guarantee that it'll eventually all click into place. But you have to deliver a message of hope and confidence, and being able to guide them and answer their questions. And I promise you, even if it doesn't work out, they will respect you and what you tried to do for them and their child, because you were honest with them and what you believed could have worked because of what you experienced with other people and what was presenting in front of you. So I honestly think just give it time, and just get with people that can help you in your professional learning, and it'll all come together. So yeah.
For sure, for sure. So let's. What are your like? If you could in rehabbing this person, and there's this, and I think I'm trying to maybe attack a little bit of a prevailing thought. That when I say someone with a labral tear, like immediately everybody who's been through PT school or athletic training school thinks, well, labral tear, it has to be fixed. You might as well, it's the same thing as like saying
Right.
meniscal tear. Well, it
Right.
has to be fixed, you know,
Right.
but what are your pearls for rehabbing someone with a labral tear? What is it that if you right now, you're speaking to the nation, if not the world on, what are those things that are like, man, don't miss X,
Right.
Y, and Z?
Yeah, I mean, you can do that's a tough one. You can do all your special tests, but they're not very good. So I think the big thing is hearing the story, correlating their story to what you're finding. Meaning, did they tell you that they haven't taken any time off? Well, let's take time off. Let's give it
Mhm.
a good couple months of no throwing, or let's look at some objective numbers. Let's measure your total rotational range of motion bilaterally, and let's figure out, are you within 5 degrees? We've put a bunch of research out that has shown that. Kevin and I, that shows a total rotational motion deficit of more than 5 degrees is correlated to high shoulder and elbow injuries. So let's look at your bilateral total motion, and figure out if there's something there that's askew. Let's measure your strength. These are all my go-tos. Let's
Mhm.
measure your shoulder strength, ER/IR. Let's look at full can, and we also measure abduction. We look at ER/IR to ratios. We look at about 60-65% external rotation to internal rotation strength on the throwing side. Are they stronger on the throwing side than their non-throwing side? Most people are not stronger on their
Yeah.
throwing side. Well, that's a huge thing. If you're not even stronger on your non-throwing side, what's your strength to body weight ratio? If your ER strength to body weight ratio is not about 15 to 20%, you're probably going to have issues with that. So let's look at some handheld dynamometry. And I guarantee if you do all that stuff and you hear their history, meaning they haven't rested, they've done a new weighted ball program, they have a new pitcher, a pitching coach they've been working on a new mechanic, or they're 15 years old and they throw 83 miles per hour. Well, they're a freak. They shouldn't be throwing that fast for them. Then
Right.
something probably finally caught up, or they had a growth spurt and something's going on. Their body has changed, or they haven't done a formal strength and
Yeah,
conditioning
let
program.
and let's dial it back and let the tissue adapt so that
Correct, right?
they can handle that
Yeah,
85. Yeah.
absolutely. They probably, if they're good, they're thrown a lot because they're on a couple teams usually. They are used a lot by both teams because they pitch well and the coach wants to win. So they pitch for both teams and their volume is just too much. They haven't rested. They're, what is it, 36 times increased risk of injury if they pitch fatigued is what that Olson study showed from Dr.
Right.
Andrews' group. Or throwing too many pitches, in a game or in a week or in a month or in a season is also correlated to injuries. So many different things besides an MRI showed a shadow
A
in my
shadow
shoulder.
that may or may not be actually there,
Right,
right?
right.
So let's, if we, one last thing I would say on that is, don't forget, and you said this earlier, when someone's doing TJ rehab, we're working on the lower body and we're working
Yep,
on the core and all that kind of
yep,
stuff. I think that's often left out
yep,
of this because maybe their mechanics are altered because they're lacking
yep,
dorsiflexion. Maybe they're
yep,
lacking that lead leg strength to be
right,
able to load and
yep,
or maybe they actually can't stand on one leg
right,
and balance, which is
right.
what they need to do for consistency and accuracy of pitching. So
Yeah, so fortunately, in my facility at Champion in Boston, we have strength coaches who know baseball. We have strength coaches in general, but fortunately, they know baseball. So get a relationship with somebody either in your organization or in your area who can help you. You don't have to do everything as a PT. You're not a pitching coach. You're not a strength coach. You're not
right.
a head coach, a physical therapist, a mom, a dad. You're not everything. Don't have to specialize in everything. You handle the PT side. You have the pitching coach handle the mechanic side. You have your strength coach handle everything else. You handle the injured shoulder, elbow, knee, whatever it is. But you work as a team for that person and you develop relationships with people in the area and they will send you people, you'll send them people. Everybody's happy. And ultimately, the kid is happy and the parents are happy because you got little Billy back on the baseball field. So develop relationships in your area. If you don't have that in-house, meaning a strength coach or somebody in-house to handle it, find
Find
people
that
because
person.
they will make you look good.
Absolutely. Awesome.
Yeah.
Well, so to kind of wrap things up here, what would be your top 3 actionable takeaways for clinicians in just our conversation here and in general?
Yeah, I think respect the literature, but also respect your experiences and listen to people, hear people out. I think that's going to be a huge thing. I think surgery is not always warranted in these situations, whether it's a cuff tear or a labral tear. I think we've talked about that. And I think just keep learning. Read the research, listen to the podcast. Social media can be a good thing. It doesn't have to be a stressful thing. So go on Twitter and follow people that you trust and respect and are speaking at national meetings and putting research out that are also clinical researches and just researches in general. I think there's so many different ways to learn than just having to go on PubMed and just pound your way through research articles, which is crazy boring. So
Yeah.
I think those three things would make you a better clinician in general. And I think the future generation of PT, it's exciting. Just hearing going to CSM and going to national meetings, it's such a great thing. There's so many different ways to learn, and this is one avenue. These podcasts are one avenue. So I'm glad MedBridge is doing this, and I'm glad I was involved, and hopefully people can learn from this.
That's awesome. That's awesome. So speaking of MedBridge, you have a lot of courses on MedBridge, and they're really awesome. But I'm curious, what are some of your favorites and why? Like, what are the ones that you, even based on today, what are the things that really would, someone's motivated by hearing you talk and say, wow, I can do this. What would be your go-tos?
Yeah, I like my overhead athlete one. I think that came together nicely, just kind of summarizing the research and some of the stuff that I do in my overhead athletes and how we treat them. I think that's a good course. I think the biomechanics of the shoulder one is good too. Just kind of take a step back and look at the overall biomechanics of the shoulder. It's one small piece. That doesn't mean we rely on biomechanics. I don't want to have people come at me. It's so complicated, but I think just taking a step back and look at the shoulder from a bigger picture is a great one as well. My rotator cuff and labrum one, I know the post-op one, again, I promote early motion. I promoted early motion for many, many years. And the research is finally telling us that through numerous studies. So it's all included in all those MedBridge courses. So I hope people can dive into those and enjoy, because it's always great working with MedBridge.
That's fantastic. So how can people connect with you? What's the best way to connect with you?
Yeah, I'm all over the place, but you can find me a lot on Twitter or X now, at LenMacPT, LenMacPT. Instagram, same thing, LenMacPT are my two things. I have a website, LennyMacrina.com, but I've let it kind of go. So find me on social media right now. Find me at
an old house kind of falling apart. The shingles are blown off.
I'm sorry, yeah, but YouTube as well. I put some YouTube content out. So YouTube, Twitter, X, whatever it's called, and Instagram are the three big mediums right now to find me for anything shoulder, elbow, knee, especially. So yeah, love helping people. I love to talk to people and get DMs from people and try to help out in their cases. So fire away.
That's fantastic. That's awesome. If you need to follow up with me, find more information about me and what I'm up to, you can find that at philplisky.com or any social media platform. But that's all the time we have today. I really want to thank you, Lenny, for having us here and help unpack some of these challenging issues and really diving into the real world. So I really appreciate you being here.
Thank you, Phil. Thank you, MedBridge, for giving me this platform, and I hope people enjoy this.
Fantastic. Well, until next time, let's keep building the future of rehabilitation and performance together. Thank you for tuning into this episode of Rehab and Performance Lab by MedBridge. Please be sure to subscribe and listen to more of our episodes on Spotify or your favorite podcast platform and at medbridge.com. If you're listening outside of the MedBridge catalog and would like to access the bonus resources and receive continuing education credit, simply log into your MedBridge account and search for this episode to find the accreditation details. Rehab and Performance Lab also listens to you. If there's a particular clinician that you'd like to hear from, or if you have a clinical question or a challenge that you would like to see addressed on this podcast, please let us know by leaving a comment on our Instagram post or by emailing podcast@medbridge.com. See you next time.